22-year-old woman is brought to the emergency department by her parents after an episode of syncope. She has a history of pica. Laboratory studies show hemoglobin 11 grams per deciliter, hematocrit 33%, MCV 112, leukocyte count 5,500, platelet count 140,000. Which of the following is the most likely association with this patient's anemia? Choice A, low activity of the MTHFR enzyme. Choice B, destruction traveling through microthrombi. Choice C, sequestration of iron within macrophages. Choice D, defect in globin chain production. Choice E, increased total iron binding capacity. Or choice F, heavy metal poisoning. I'll wait 5 seconds and answer the question. This is an anemia question. And the first thing you should have noticed is that this patient has an increased MCV 112, which is above 100. On step one, if you get a macrocytic anemia, 9 times out of 10, it's going to be a question about B9 or B12 deficiency. And the reason both of these get a macrocytic anemia is because a deficiency in either one would cause deficits in DNA synthesis. And one of the many reactions involved in DNA synthesis is the conversion of vitamin B9 to its active form, 5-methyl THF, via the enzyme methyl N-tetrahydrofolate reductase, also known as MTHFR. So choice A is the correct answer. So that, of course, is just a biochemistry connection that you should be familiar with. That whole tetrahydrofolate and homocysteine and methionine kind of pathway. And of course, you should also know that if I asked you to differentiate between B9 and B12 deficiency, one of the ways they really like for you to know the difference is through a elevated methylmalonic acid level that would be found in B12 deficiency, but not B9. And of course, when we talk about B12 deficiency, we think about a lot of other things like pernicious anemia, right? Destruction of parietal cells in the stomach that produce intrinsic factors that help to absorb B12 at the terminal ileum. There's also an association with Diphyllobothrium latem, the fish tapeworm, with B12 deficiency. That's not as high yield, but it's just one of those things that shows up every once in a while. B9 deficiency is more common in B12 because B9 only has a couple months of storage in the body, whereas B12 has several years worth of storage. So usually when you get B12 deficiency is because there is some kind of long-term problem that prevented you from getting B12. Like I said, problem with the intrinsic factor, problem with the ileum, fish tapeworm. Just a lot we can talk about, right? But as far as these sort of anemia questions go, when you see a high MCV, you should be happy because that narrows the differential down a lot. So let's look at some of the other answer choices here because they are not macrocytic, right? Choice B, destruction traveling through microthrombi. This is referring to MAHA, microangiopathic hemolytic anemia. So in these, you would typically find low platelets and schistocytes on blood smear. If anything, this would have a microcytic anemia because you're destroying red blood cells. But it's more important that you would see schistocytes, which is the torn up red blood cells because the platelets aggregate on the endothelium. Red blood cells try to pass through and they get sheared by the platelet plugs as they pass by. So the classic example you get to hear a lot of is HUS, hemolytic uremic syndrome, caused by E. coli 0157H7. Reduces Shigella-like toxin, and of course can also be caused by Shigella itself. But if this patient had that, then we would have a history of diarrhea, bloody diarrhea, in fact. That is the classic presentation. Some other things that can cause MAHA, TTP, thrombotic thrombocytopenic purpura. We do have the low platelets in the anemia here, but once again, we don't have schistocytes, and we don't have a lot of the other clinical symptoms we would associate with it, right? We would usually see petechiae, and probably confusion is something they like giving in TTP, neurologic symptoms of some kind. And the other one is DIC, right? Which obviously this is nothing like DIC. DIC, you would see a lot of blooding and clotting problems. Patient would probably just generally be in way worse shape than what it sounds like here. Choice C, sequestration of iron within macrophages. This is referring to anemia of chronic disease. I mean, this patient isn't mentioned to have any sort of long-term health problem that would cause this. And once again, it wouldn't have a macrocytic anemia. If anything, it would have a microcytic anemia. Sometimes it's normocytic, but the point is that it probably wouldn't be macrocytic. Very, very unlikely. Choice D, defect in globin chain production. This is talking about thalassemia, which again, you would probably have microcytic anemia. And this patient doesn't seem to have a family history, which is something they would usually give you, or at least they would give you either a family history or they might just straight up give you electrophoresis or genotypic studies, that sort of thing. Another way they like presenting thalassemia is that they'll give you a microcytic anemia, and then the iron and ferritin levels are normal, which tells you it isn't an iron deficiency anemia. Or they'll tell you that a patient has microcytic anemia, and then they give them iron as a supplement, and their condition doesn't really improve, which implies that it's a thalassemia. So speaking of iron deficiency anemia, choice E, increased total iron binding capacity. This is referring to iron deficiency anemia for the most part. If you're confused by what total iron binding capacity is, you can think of it as like the number of quote unquote free spaces there are on transferrin for there to bind iron. So if I have an iron deficiency anemia, I'll have low iron and low ferritin, but I'll have a bunch of open spaces for iron to bind that aren't getting bound because I don't have enough iron. And we call that higher total iron binding capacity, or that's just one way of talking about it. So you would have a higher TIBC in iron deficiency anemia. So as far as this question goes, pica is actually pretty strongly associated with iron deficiency anemia. But as I've said again and again, you wouldn't really see a macrocytic anemia in iron deficiency anemia. You would have low iron, low ferritin, high TIBC, and a microcytic anemia. And once again, choice F, heavy metal poisoning. Well, this can imply a number of different heavy metals, but usually it would be referring to lead poisoning on USMLE, which also leads to a microcytic anemia. You could also see ring sideroblasts and basophilic stippling. You also want to know that lead poisoning, or just lead in general, is disruptive to two parts of the heme synthesis pathway, which is where ALA dehydratase turns delta aminolevulinic acid into porphobilinogen, and the other one it interrupts is ferrochelatase, which does the final step of changing protoporphyrin 9 into heme. Again, you get what's likely a microcytic anemia, a sideroblastic anemia, not macrocytic. So bringing it back, you just gotta know macrocytic anemia. It's almost always B9 or B12 deficiency on USMLE. You really shouldn't be getting these kind of questions wrong. I hope you found this video helpful. I'll see you in the next one.